Chapter 5, Infection Control, Transmissible Diseases. This is the chapter that's going to help you fill out your sterilization packet, or one of the chapters. So, objectives for the dental health care personnel. We see DHCP as dental health care personnel or dental health care providers. So the whole objective is to protect the patients, personnel, and others in the office or clinic. It's the entire team's responsibility, and every school, as well as every practice and specialty, needs to have work practices in place to prevent cross-contamination. First, the entire dental team must organize and maintain a system for sterilization, disinfection, infection, and care of the instruments and equipment. Secondly, the dental team must develop and maintain work practices for all appointments and patient contact to prevent direct or indirect cross-contamination between the dental health care personnel and patients, or from patient to patient. So that's how we come up with standard precautions. Our entire industry works with standard precautions. If we have a standard precaution that goes across the board for all of the dental practices and schools, then everybody likewise seems to put together a like-minded process. So this is a new definition for infection control, standard precautions, just as of a few years ago. They used to, for, 40, 50 years, they called it universal precautions. That focused on the risk of transfer of only bloodborne pathogens. So they had a process for only things that had to do with bleeding or bloody gauze or any needles that had blood drips in them and the like. The new definition for infection control is from the CDC also, and they recognized that other body fluids besides blood also carry infectious agents. So number one, you integrate and expand the elements of universal precautions. So we keep the universal precautions, the old one, as of having a process in order for blood. They just added non-intact skin, mucous membranes, and what they did, it's supposed to protect all dental health care personnel and their patients from pathogens that can spread by blood, all body fluids, excretions, secretions, all except for sweat, regardless of whether they contain blood or not, or contain non-intact skin or mucous membranes. So they just added to this universal precautions to include everything that we really deal with. Other precautions include airborne droplets. You get that from sneezing and coughing. You can transmit tuberculosis, influenza, and chickenpox from airborne droplets, just sneezing and coughing. Contact precautions. We reduce the transmission of organisms and specific diseases by direct skin or indirect contact. For example, Staphylococcus aureus. So we put processes in place to prevent that. Another precaution are airborne precautions. It's reducing the risk of airborne transmission of infectious agents by droplet nuclei, by requiring special air handling and special ventilation. For example, tuberculosis aerosols. This is in the case of someone not only coughing or sneezing, but all of the use of the hand pieces and that the dentist uses, and the hand pieces that we use as far as polishing and the Cavitron, the ultrasonic Cavitron. So all of those things produce an aerosol, and they hang in the air. The lighter they are, the more they hang in the air. If they're heavier droplets, they fall quickly to the ground because of gravity. So microorganisms of the oral cavity. So in utero, our oral cavity is sterile. So within just a few hours of birth, a simple flora develops that we need. Microorganisms then are transmitted from mothers and other caretakers, kissing all over the mouth and the face. And as the infant grows, there is a continuous introduction of different microorganisms. Many bacteria come from the top of the tongue or the dorsum, mucous membranes, gingiva, and periodontal tissues. Intact mucous membrane provides some protection against infection. Intact mucous membranes are like the insides of your cheeks are soft. Those are mucous membranes, and as long as you don't have a bite mark or any kind of a breakage of the mucous membrane, it's considered intact, and so it's providing some protection into our system. Disease-producing, potentially disease-producing, or non-disease-producing microorganisms may be present in the mouth of every single patient. So these pathogenic organisms may be transient, meaning that they can go from place to place. Cross-contamination, and you would need to know this in red. Cross-contamination can be from person to person to inanimate object, like a person to a pen, a writing pen, and an inanimate object to another person. So let's say that I have my gloves on, my exam gloves on, and I'm inside the patient's mouth, feeling around their teeth with my gloves. So those gloves are considered contaminated to anybody but that patient. So let's say that I reach up and I need to write something down, and I reach up and take a pen off of the counter or my computer tray, and I start writing something with it, and then I put that pen back down, with my gloves on. So now the pen is contaminated, and also the tray is contaminated, and then I will put the gloves back in the patient's mouth. So if the pen and the tray were not sterilized, I'm also transferring contaminants and possible pathogens from the pen and the tray right back into the patient's mouth. So there's a transfer. You can go person to person or person to inanimate object to another person. So let's say that the hygienist in the room next to me, particularly I'm talking in school, is needing a pen real quick. She sees a pen and on your tray, and she picks it up and says, "I'm going to borrow your pen real quick." And she could or could not have gloves on, and she takes that pen. So you can see how then it is, especially if she doesn't have gloves on, it's now, you're not only getting contaminants off of the pen and the tray themselves, but you're getting the patient's contaminants onto the skin of the other hygienist. And if she happens to have a little hangnail or a paper cut or something on her tissue, now it's in her system. So that's cross-contamination. So I'll let you go through these review questions and answers. So here is the chain. You're going to see this quite a few times in your program here, where you start with this infectious agent up at the top. I'll go through this rather quickly. And we use standard precautions which help to protect against all these infectious agents. Okay, so bacteria, fungi, viruses, protozoa, etc. So then you have to have, once the contaminant is introduced, like let's say into your patient's mouth, it could be from that glove or the pen, whatever, there has to be a reservoir. So people can be a reservoir. It's just a place where the bacteria or microorganisms can kind of linger and hide and embed themselves in. Your equipment are reservoirs for bacterium, your instruments, water from the tubing, etc. But once again, as long as we use standard precautions and treat everything as if it were infectious, and every patient as if they were infectious, then we will put in processes to avert this, and it won't go any more than this reservoir. But let's say that it does, the reservoir then links to a port of exit. The port of exit is like secretions, saliva, blood, skin and mucous membrane, or droplets from the air. Okay, so we use a certain waste disposal to help guard against this. And once again, if we use standard precautions on any of these links, it can break the chain. But there needs to be a port of exit. Then there needs to be a way to transmit it to an inanimate object, another person, or an inanimate object to a person. So you can have direct contact, indirect contact, or it can be airborne from coughs, sneezes, etc. So then you have to have some kind of port of entry. So if that other hygienist picked up a contaminated pen that had been in someone else's mouth that possibly is contaminated, and well, it is contaminated, but maybe they had something even more serious, then it's gross and not sterile and completely unprofessional. But if there's no port of entry on that other hygienist's hand, then there's no port of entry until they can wash their hands really well, and it may not affect them. But if they have a port of entry, like maybe they bit their cheek, maybe they bite their cheeks as a nervous habit, a potato chip or taco chip or something like that, made a little scrape on their mouth, or they just had a tooth extracted, etc., that could be a port of entry into the mucous membrane. It could be go down the GI tract. It could be on their saliva and they swallow it. So now it's in their GI tract. If it's some kind of an airborne aerosol, it's now in their respiratory tract. And particularly if they have broken skin, and then before they go over to wash their hands and rid of this, they feel like they've got something in their eye, and they put their finger up to their eye. Well, now it's in their eye. So even though you have this whole chain, if everything kind of went wrong and it kept building and building like this, when it comes to another person, that you have to have a susceptible host. So if someone is super healthy and nothing's going wrong with them, then very possibly it may still not affect them. May not, dependent upon what the contaminant is. But if you have a patient who is immunosuppressed, medically compromised in some way, elderly, and even the really young, then this would be a susceptible host, and they could very well come down with something. But once again, if we use standard precautions along the way and treat everything as if it were contagious, every person as if they were infectious and contagious, then most probably we would not have taken our gloves out of our patient's mouth and reached up to use a pen and contaminate the pen and the tray and everything in the first place. So that's how you can break the chain of disease transmission. Airborne infection, that can be dust-borne organisms. Surface disinfectant helps control that. You just have to use a surface disinfectant. on your countertops, etc., around the sink. Aerosol production. Aerosols are contaminants breathed into the lungs. Spatter or drop on objects and people, like spatter from your polish or when you're polishing the teeth. And of course, it has saliva and possibly blood mixed with it. And it can, if you are running your polisher on a really high speed, it can kind of throw out spatter. And the contents. You can have single spatter or clumps of microorganisms, just depending. The concentration, spatter and aerosols are going to be greater close to the activity. So the further you get away from the mouth, the less concentrated that those things will be. Prevention of transmission. We always gave a pre-procedural oral hygiene rinse. Always before we had the patient swish with the rinse before we even put our hands in their mouth. And this always was thought to cut down. It just reduces the amount of bacteria in the mouth right to begin with. They now feel like that isn't really doing anything. It just doesn't reduce it for very long. And so very quickly, all the microorganisms can come back. So they've kind of done away with that. Some people still like to do that, even for just the smell, if someone's really got really bad, severe perio. And they may still give them a pre-procedural rinse. But the American Dental Association and the CDC is saying that they're not sure that it kind of gives a false idea to everyone that in the entire hour that you're working on the patient, or in school even longer, that it's going to be a lot less bacteria in the patient's mouth, and they're finding it's not true, that it can come back pretty quickly. So they're not suggesting that everyone has to do this. Interruption of transmission can be done with the dentist uses a rubber dam it blocks the throat area when the dentist is doing some procedures. We use a high vacuum. High vac is what we call it. And especially now with COVID, we're going to have the high vacs on all the time to help reduce the aerosols in the air from procedures that we do. Filters are great. Your offices and the school needs to have really good ventilation and relative humidity. So clean water. We always run the water through the lines for at least 30 seconds at the start of the day, after each patient, and at the end of the day. Now, once again, it's always been and may still be on board questions and test questions. It was always 2 minutes that you run the water for, and it seems like it's like 2 minutes just holding, letting water run out of your line. It just seems like, 10 minutes. It just seems so long to sit there and do that. But that was the rule, to do it for 2 minutes at the beginning and end of each day, and then 30 seconds between each patient. But we have a backflow on our system, and so the backflow does exactly that. It helps stop any backflow from going into the suction. So because we have that, they're relatively inexpensive. All offices really should have them. Because of that backflow little clip that we put on our tubing, we only have to run the water for 30 seconds at the beginning and end of each day and in between the patients. So protection of the clinician, we use masks, shields, protective eyewear. It can all prevent direct control of spatter and aerosols within your face and eyes, and for those around you. Protection for the patient, we have them use eyewear, prevents the spatters and aerosol into their faces and eyes. Sometimes you're going to get patients who say, I don't want to use those, or I don't have to use those. and you just simply say, I get your point that you know, don't like this, but it really helps prevent any aerosols and bacteria from getting in your eyes. And that usually was enough. The patient went, oh, you know, okay. And so they will go ahead and put them on. And in this COVID time that we're living through, they for sure will comply with that. Pathogens transmissible by the oral cavity. Once again, tuberculosis, viral hepatitis, AIDS, and herpetic infections, herpes. Tuberculosis, the types of TB. Tuberculosis can be drug resistant, multi-drug resistant, or extensively drug resistant. So the transmission with tuberculosis has to do with your lungs, so it's through inhalation, breathing it in, and urgent dental care in a facility that offers isolation is what they need. We can tell this right off the bat from going over the health history first before we even enter the patient's mouth. Now, the picture here is a look of someone who has tuberculosis. Sometimes they can get this on the back of their tongue, like these two little spots right here and here. So if a person opens their mouth and you're seeing that, then when you come to get an instructor, you're going to let us know that you see some, we're going to call them lesions because that's what we do, with any type of deviation from normal. And this does not look like a normal tongue. It certainly looks like it's deviated from normal. And you would be marking that down and come get us and we could tell. Someone who has tuberculosis is most probably not going to show up in our clinics, because if they have tuberculosis and they know from a doctor for sure, they're already told not to go to an office or a clinic to go to the dentist. They have to go to a special place that's all closed off and, you know, really watches with a contamination. They don't come in. But what you will have from time to time is they will mark TB on their health history. And then when you interview with them and you sit down and go over the health history with them, you can say, I see that you marked tuberculosis. And they'll say, oh yeah, but I had it 20 years ago. I had it 20 years ago and it's okay, it's all gone right now. So we take them at their word, and they will go, that's okay. So we're not afraid of getting tuberculosis from those type of people. So I'll let you once again go through that. This is droplet nuclei. These are just really tiny and even smaller than this, particles that you can't see. Are suspended in air. The lighter ones kind of hang in the air, and they can sometimes hang in there for hours. And you breathe them in the nose, and then there they go in your lungs. Now they're in your lungs. Use of an ultrasonic and other hand pieces and air water spray can create aerosols that carry the tubercle bacilli, most definitely. So droplet nuclei are small enough to pass through over 95% of bacterial filtration efficiency, required of standard surgical masks, and may remain suspended in the air for hours. And this is why you need to use at least a level 3 mask for stopping anytime you're going to use Bicavitron, and definitely now it's why we use in 95s when you're going to be using that. So for those of you who have not been in the dental industry before, this is what an ultrasonic looks like. It's because it has an ultrasonic action to it. It's a vibration with water that sprays out, and it can remove all sorts of calculus and lavage the gum tissue underneath the gum out really well to provide healthier environment. and they come in different types. There's a Cavitron, which we have, and we also have a piezo. You'll be using those and being introduced to those at the beginning of next term. So the risk assessment conducted for tuberculosis is annual. You're going to have an annual test, a TB test, and if you're in private practice, I don't know if many doctors really pay for that. It's something that if you are really caring about your health, that you need to go get on an annual basis and make sure that everything is copacetic. So a referral, the end of the appointment, patients with symptoms suggestive of TB infection are referred out to a doctor. And once again, I haven't really seen much of this, but if I truly suspected someone of a tuberculosis infection, I would reappoint them at another time and not even go into the mouth and have them referred out. If someone came in with a tongue looking like that and maybe they didn't know that they had tuberculosis, and that's something that we would rule out for our protection and the protection of all those around us. So we would not be seeing any of those patients until it was cleared up. So these people are treated only in a facility with an airborne isolation room. So that's where they need to go. So now we're going to go to viral hepatitis. Hepatitis, anything with hepa means liver. Anything hepa is liver, and itis is inflammation. So it's a viral infection, which is an inflammation of the liver. So the word really tells you what organ is affected. The causes could be viral or bacterial infections from toxins and certain medications, or from heavy alcohol use. Viral hepatitis has many different categories. They have A to G in their categories, these letters, and I just put them up because they have different routes, how they get into your system. A and E is an oral fecal route. This usually comes from the food industry when someone gets food poisoning or they get E. coli in the food or water. It has an issue with it or contracts hepatitis. They would either have category A or E from either from oral or fecal. B, C, and D are the ones that we mainly are in contact with. These are bloodborne route by contact with infected body fluids. So this directly impacts us, but the risk is really low. Prolonged exposure to this environment is necessary to really contract it. So you would have to have that same patient back like every day, and be having or have all of your patients have this hepatitis for you to for quite some time before you could contract it. So F and G are they just added those within the last 5 years or so. They're new and they're usually transfusion transmitted. So people with IVs or drug users, or it's anything with a transfusion. So we're not going to see that type in the office. So that's how those are transmitted to another person. So you'll need to know those, particularly A and E, being the oral fecal route. I know students before have thought of restaurants with an A, beginning with an A and an E, and that's how they remember that it has to do with the food industry. And that the other ones, those other ones in the middle, B, C, and D, are from the blood or infected body fluids. So hepatitis B, this is the acronym for hepatitis B. It's hepatitis B virus is what the HBV stands for. It's very serious. It's endemic. It's worldwide, so it's a pandemic disease, or endemic meaning it's in certain areas, um, um, collected areas, and it can be spread that way. So with the use of strict sterilization, aseptic techniques, and self-protection, we can avert this. It's absolutely um, mandatory to have the best sterilization. And so causes serious illness. It can cause cirrhosis of the liver. It can actually cause liver cancer, disability, and maybe even death. So you transmit hepatitis B, once again, that's the blood and other body fluids, through contaminated objects. So which objects? IVs, um, needles, and sexual contact, etc., can even spread hepatitis B. So the perinatal transmission is mother can transmit it to the fetus. The carrier state, you can just carry it and not have actual symptoms, or you could have chronic hepatitis B. And the immunity to this develops, your body will develop antibodies after you're once infected, and it can help with the immunity. We definitely have hepatitis B in shots, and there needs to be 3 in a series, and you're seeing for those, they have them spaced out at the length that they're supposed to be. So as far as I know, I think all of you have the hepatitis. I don't even think you can come into the school and be a student without having a hepatitis B series, and we certainly had to. When I went into an office, I had to show that I had a hepatitis B. So prevention, how do you prevent it? They could do prenatal testing if they suspected a mother of having this. Universal immunization of infants and children, immunization of adults and adolescents, enforced blood bank controls, screening of all donors and rejecting those with a history even of viral hepatitis, drug addiction, recent transfusions, or someone's that has had recent tattoos would be rejected, and travelers from a hepatitis B virus endemic area. So there's strict testing on all donated blood, need to enforce the use of disposable syringes, and for needles for acupuncture, skin testing, body piercings, inoculations. If you can do that, that's a great prevention. Just general education of the public. So for hepatitis B, there is a test for that. There's a vaccination for that, and so you have both. Now we're going to go to hepatitis C. Hepatitis C is by a needle with an IV, either a needle percutaneous. Cutaneous is skin, so it's per is by, it's by the skin. It's by a needle. Parenterally is an IV with a needle, with a transfusion with an IV bag, or IM, which is intramuscular injection. So if blood can transmit hepatitis C, sexual contact with infected partners. So you can definitely transmit it that way. So for hepatitis C, there is a test, but there's no vaccine. There is, they now have a treatment. They didn't always have a treatment until recently. Last few years, maybe, I lose track of time, maybe even up to 5 years or whatever now, but prior to that, they didn't have a vaccine and they didn't have any treatment for it, so it was a pretty big deal. Now they do have a treatment. It's still a big deal, but they at least do have a treatment, because it can cause cirrhosis of the liver and cancer, and so we're going to help prevent it for ourselves by using standard precautions. And education of the healthcare providers. Hepatitis D. Hepatitis D is called the Delta agent. I've seen that in, which hepatitis is the Delta agent from. So it's easy to remember because Delta and D. So the Delta agent would be hepatitis D. This cannot cause an infection except if you already have hepatitis B. So if you are exposed to hepatitis D and you do not have hepatitis B, you will not get hepatitis D. So if you have been exposed in an infection with hepatitis B virus, then you can get hepatitis D on top of it. So how do you transmit it? It's superimposed on HBV carriers. So if someone is a hepatitis B carrier, they can also transmit hepatitis D. Multiple exposures, if you're a healthcare worker in the medical field for, hospitals or community health places where people have hepatitis B virus and you have multiple exposures to it, you can get it that way, especially with patients with hemophilia and IV drug users. So contaminated blood, you can get it from body fluids, meaning saliva, any kind of fluid that way, needles, sexual contact, and perinatal transfers. So pregnant mother can, if she gets it, can transfer it to her fetus. The prevention of this would be immunization always with an HBV vaccine because you don't have to get an extra hepatitis D vaccine because if you don't have hepatitis B, you're not going to have hepatitis D. So the herpes, let's go to herpes virus diseases. The viruses are endemic worldwide, global worldwide, which would be if they would get outbreaks everywhere. Like we're in a COVID pandemic because it's actually affecting everywhere in the world. Endemic, it's that the whole world can get this. There's sections, that will be transmitting this, and maybe they'll have a rise in a particular town or a particular village or something in places around the world, but like not the whole country or whole state. So each virus causing many diseases, entities that are highly, highly infectious. So up to 90% of all adults have been exposed already to herpes because we've developed antibodies to the virus. And if you get you call it a cold sore, it's a herpes virus is what a cold sore is. A fever blister is a cold sore, is herpes virus. Now, a canker sore is not. That's something very different. But a cold sore, fever blister, herpes, it lasts from beginning to end, like 7 to 10 days, once in a while up to 14 days on some people. These are fluid-filled little blisters that are like little vesicle blisters, and they come on very slowly, and then there's a bump, and then it's a harder bump, and then it begins to open and ooze. So then when it has done that, then it will start to dry out and a crust forms. So the very most contagious, part of the herpes is like the day before you get it. So maybe your lip will start to kind of tingle. Some people don't even have kind of a warning. They just wake up and they've got a cold sore on their mouth. Even stress can even produce herpes in some people once they have been exposed to it. But it is a huge health problem because there's lack of effective medicines and drugs for it, which we call therapeutics, and there's a lack of effective vaccines for herpes. So there's only 8 strains of herpes that they infect humans. There's many more strains of herpes, but only 8 of them can affect humans. And herpes can produce diseases with latent, meaning that you can harbor it in your system and it will lay dormant for a long time, and then all of a sudden, some point in your life, it'll come out and start to infect. You'll start getting the symptoms for it, and it's recurrent. Once you have it in your system, and so then it lays dormant for a while, and then it comes back again, which is what recurrent means. And sometimes, even rare occasions, it can have malignant tendencies. So most get herpes virus 1 as an infant or a child. It can spread by skin-to-skin contact with an adult who carries the virus, is kissing all over your baby, or is taking a lick of something and then feeding it to your baby. Could be members of your family, aunts, uncles, grandparents, you know, brothers, sisters, whoever. An adult does not have to have sores on their mouth anywhere or in their mouth to be able to spread the virus. So sharing a towel can even spread the virus. So herpes 2 is usually from sexual contact, and it can spread and is contagious. It can spread from person to person. So herpes 1 is usually the genitals, but herpes 2 can you can spread herpes 1 to your genitals during oral sex. So once infected with herpes virus, it never is going to leave your body. It's kind of like chickenpox, and perio disease. It just kind of, you have to maintain it. So after the first outbreak, the virus moves from the skin cells. First it's on the skin cells, then it goes into the nerve cells. And sometimes that's why it can feel tingly, sometimes right before it breaks on someone's lips. The virus stays in the nerve cells forever. So it can be dormant, like I said, for literally years or decades, and then become active with certain triggers like stress, illness, fever, surgery. So there's a lot of people who I have known that will have herpes, and some of them were dental hygienists, and later in life they would get these bouts of herpes, and they would say, I know this is due to stress, but there was never a more stressful time than when I was trying to, go through school and pass tests and all that stuff, and I never got them then. Why am I getting them now? But it could be kind of a combination. If you kind of have recently had a fever, an illness, you're under stress, or you've just had surgery. I mean, it all has to kind of fall right for it to come out. So we reschedule these herpes patients if they are in the early stages of the herpes where it's most contagious. We cannot refuse to treat anyone, but it doesn't mean we can't reschedule them until they get healthy if they have something contagious, so that it does not spread to the healthcare workers. And herpes is hugely contagious. So you can see this trigeminal ganglion right here up by the, in front of the ear. Preauricular is, but it's inside. And this is what's going to take your nerves from the eyes. And you have your branch that's for the maxillary teeth and the mandibular teeth like this. And it all comes from the trigeminal nerve, and where it meets is called a ganglion, and this is where the virus goes and can sit in the nerves of the ganglion and remain dormant for a very long time. So they can be reactivated Could even be from ultralight with tanning beds, or repeated exposure to the herpes virus itself. So we don't treat these people until they're healed. The relation to perio infections when you have herpes. The virus occurs in periodontal pockets in very high levels, underneath your gum tissue. Herpes suppresses the immune system, and so it results in overgrowth of pathogens, bacteria in your pockets of the teeth. So periodontitis, inflammation of that area subgingivally, becomes even more severe. And if your immune system has been suppressed, your healing could be slowed. Images of the conditions below will follow. So you've got herpes simplex virus type 1, and you can get primary herpetic gingivostomatitis. And once again, with medical words, you just have to break them up. When they have two nouns, they usually put an O in between to hook them together. And we always say the very last part of the word first. So it's inflammation of the gingiva, and stoma is mouth, anything in the mouth. So it's inflammation of the gingiva in the mouth, or anywhere in the mouth, is what primary herpetic gingivostomatitis. Breaking these words up like this can also help you pronounce them super easy. So then there's herpes labialis. The labial is facing your lips. So it would be like in the anterior region of your mouth, and just inside your lips, either on the inside or on the actual lips. There's herpetic whitlow, which is herpes of the finger or thumb. And there's ocular herpetics, is when you are touching that and accidentally touch your eye, you can transfer it to your eyes. So this is primary herpetic gingivostomatitis. This is just an area, any kind of a red area. It could be here, it could be on the tongue, it could be over here. Anything that you're not sure what it is, it's inflammation of the mouth. They could have stomatitis, or a gingiva here that's on the gingiva. You can see these little spots right here. Now, sometimes spots like these are if a person has been eating a lot of potato chips the night before, and they, or some other kind of really hard chip, and we've all had that, to where it's kind of scraped the tissue, and then it heals in a few days of that. The mouth heals pretty quickly in comparison to other parts of your body. So here's some more places. So what I usually do when I see these is ask the patient, I see some, have you eaten any chips or something? It looks like the tissue is scraped, because they can understand that. I don't say, ask them if they have gingivostomatitis, for obvious reasons. So I'll say, it looks like your gingiva has been scraped off a little bit. Is that sore? And they'll either say yes or no. I didn't even know anything was there, or yeah, it's really been bugging me if I eat something salty. And so you can, and then maybe they'll say, I get those every once in a while, and I'm not sure what it is. There's kind of a difference between just a scrape and when you first look at it. And until you get your loops with the magnifier on them, this would cause some, you're not sure what it is. You're going to tell us that there's some lesions on the palate by whatever tooth this crown is, and on the lingual side. So, and then we would look at them, and if we can't quite tell, we'll go get a dentist. And so if they think that that's what it is, we will reappoint. But it could be all swollen and have lesions. This is herpes labialis virus. It's on the front of the mouth. And so these are all herpes in different shapes. Sometimes it's round like this one right here. Sometimes it's in like a little group. These that are going down like this over here would be like coalescing. They're kind of falling like leaves on a branch, kind of falling, scattering down. And this is just this poor child. This is just all over everything. This poor little person had it and transferred it to their eye, and now they've got ocular herpes. This is herpetic whitlow. It can be on your finger. It can be on your thumb. They had maybe little pieces of tissue here that sometimes happen around the cuticles. This person maybe, bites their nails a little bit or doesn't really take care of them all the time, and there was a break here, so they get it an infection there. There had to be some kind of break in the skin there for it to get in. And these, it can be as bad as this one, which is really bad, or this, and just kind of eat the skin right off of the finger almost until it heals up. And here is another really bad case. And it's highly contagious, so you get that, you're not going to be working for a while. So let's move on to herpes virus diseases type 2. This is commonly known as genital herpes, but it doesn't have to be genital. It's just more often than not, it comes from a genital herpes. So it may occur as an oral or perioral infection. Oral is, of course, the mouth, and peri is around. So it's something that's around your mouth, kind of on your lips, like those pictures. We are going to, in front of our patients, use a cold sore or fever blister to avert any embarrassment by the patients. So the clinical management, you only postpone your appointment if it's full-blown, which means contagious, which is right before it's crusting. So if you get to that crusted phase, as long as you can't see any moisture coming out anywhere or anything, then that would be fine. But if you are seeing those vesicles and there's oozing at all, you can see any moisture coming out of those, that's highly contagious at that time. They could be completely crusted except for a couple spots, little tiny spots. You're going to reappoint them. Okay? So always confer with one of your instructors before you proceed with that appointment. Then we have another herpes virus is varicella zoster, which is herpes virus 3. And this is the VZV is the acronym for this, but it's actual herpes virus 3. That's chickenpox and shingles. So chickenpox is the varicella part. This is from respiratory droplets and direct skin contact with all that little vesicle fluid that's coming out of like scratched or broken open chickenpox marks. And so you need to remember that chickenpox and varicella infection is the same thing. The zoster part of this virus of HHV3 are shingles. So the reactivation of this may occur years later in the form of shingles. So what happens is that chickenpox stays in your system, like I said before, forever. And so it just lays dormant. And if you've been exposed to chickenpox, sometimes later on in life, you can have some kind of something that will trigger the reactivation of the varicella zoster, and you won't get the chickenpox, but you'll get the shingles part of it, which is the zoster infection, where they have, and you'll see a picture of that shortly. Then you have the Epstein-Barr virus. Okay, that's a herpes virus also. It's infection mononucleosis, herpes virus disease. It's infectious mononucleosis, comes from Epstein-Barr. I would know that for sure. And that's transmitted by saliva, which is why they would call mono a lot of times the kissing disease, mainly because it's transferred by saliva. You can get oral hairy leukoplakia if you're immunosuppressed and become infected with mononucleosis. So these are pictures of varicella zoster that comes from herpes virus 3. This is the shingles, and it kind of goes a lot of times on the trunk of someone. You can get it on your legs or anywhere, but more often than not, older people get it on their backs. Could start a little bit on their stomach, but it will go on their sides and onto the back. So chicken pox or varicella, of course, there's going to be red spots and then a blister and then a hard crust. So this is what it may look like on the outside when they have gotten over chicken pox, but they're just waiting for some of these. They're not all crusted, but I just wanted to show you that they could still have some marks. They're not all, I think, crusted over yet, but if they were like this one right here, it wouldn't be contagious. But sometimes they'll open their mouth. Let's say they have a shirt on and they've got shingles and they don't happen to say anything, or they're just getting over the shingles, so it doesn't hurt so bad, because I've never had that, but I have in-laws who have had it, and it's very painful. So they would have to be kind of getting over it before they would probably even just want to even lay in your chair. But they could open their mouth and you could see spots like these around on the tongue, and that could, with further investigation, you could find out if they recently had shingles or the chicken pox, which is the varicella zoster. Here's the mono. It's type 4. It's virus 4, herpes virus 4. And you're going to see this a lot of time when we are doing head extraoral examinations. Sometimes the person's hair is down, so you're not really seeing this, and you're feeling around in there. You're going to feel some bumps. Usually bumps are, I had bumps when I was a kid, and they are tender to the touch. So any of this could, actually mono could kind of look like this too. Your tonsils can swell almost so big that they almost close your throat. But here's some back here that can look like the mono. They may have a fever, which they won't be coming in any offices if they have a fever due to COVID, but fatigue, sore throat, and swollen lymph glands. This is hairy leukoplakia, and they call it hairy because the papilla, we lose our papilla and gain new papilla like every 21 days or so. These are not expelling out, so they are growing a little longer, so it kind of resembles hair is how it gets its name. Plakia is any kind of a plaque or patch, and leuco, of course, means white. So it's a white patch, and it can go anywhere. It can be on the buccal mucosa, down in the vestibule, wherever. But this part right here, when you're looking at the sides of the tongue, and you see this, then you know that they have leukoplakia. It could be white or gray or almost kind of bluish gray. On the tongues, the gums, the roof of the mouth, or inside of the cheek. Sometimes they come from just irritation of a rough surface, like of some filling. Maybe one of these fillings down here on the inside, on the lingual side, is kind of chipped or it's kind of sharp, and it just keeps rubbing right there, and that can form leukoplakia. It can come from an ill-fitting denture. It can come from smoking too much, sun exposure to the lips. You can get it around the lips. If you have HIV or AIDS, you can get bouts of leukoplakia. The treatment is for this, though, is usually you remove the irritation or fix the tooth, whatever is causing it, and usually it'll clear up in about 2 weeks. They stop smoking or um, whatever it is they're doing, it will clear up. This is called black hairy tongue because this is the same kind of deal. Yeah, the papilla will shed every 21 days, and these are not shedding. So it looks gross and it looks like hair all over the tongue. And this black part of it, it's a bacterial fungus, and it builds up on the papilla, and instead of shedding, they just grow longer. So the reason it's getting its color could be from food, smoking, a soft diet, being dehydrated. Some medications that you're taking can cause this to turn these colors brown and blackish, and very poor oral hygiene. Sometimes it will happen due to medication, even though they have pretty good hygiene at home. You want to tell these people to brush at least twice daily and use a tongue scraper. So I don't know. I think I'm very big on words, but I think I'll massacre this word. Cytomegalovirus. The CMV. These signs are identical to mono, and that's CM5. That's a herpes virus also. The herpes lymphotrophic virus is 6. Human herpes virus is 7. And Kaposi's sarcoma is a related herpes virus. They'll call it K for Kaposi's sarcoma related virus is how they get this acronym, and it's termed AIDS, and this is AIDS related. So I would know that for boards. These you don't have to. I've never really heard much about them. You need to know that there's 8. I have seen this, but only in a multiple choice questions where one of the answers are this, but I never find that this to be an answer. So it's usually the ones we've already talked about and 8. So this is what Kaposi's sarcoma could look like. This is definitely from sexual contact. So it can show up on the hands like these purplish things. It can show up kind of flat or dull like this one down here. It can be shiny and raised like this one right here. It could be this small or much larger like this. On the inside of the mouth, it can look kind of purplish. You can see it like right there. This is raised with, it looks like 2 little breaks in the skin, and it looks like there's some stuff equally going on right there. So you're going to come get us and say, I'm not sure what this is. We're going to take a look at it and look at their medical history, and then possibly have a conversation. So it can be malignant neoplasm. Neoplasm is another word for growth, and neo is new, so it can be kind of a new growth that comes up in the skin, the mouth, can go down your GI tract and down your respiratory tract. This is a really large one, and it is kind of hooked very tiny by here. So this is a tumor, Kaposi's sarcoma tumor. This is from an HIV positive patient with an intraoral lesion with an overlying candidiasis infection on top of that. Usually they only find this in men for some reason. Candidiasis is this white patch that's over, there's patches here and there. It looks like it's a fungus, and it kind of looks like sometimes when you're actually viewing this in the mouth, because you can get it just on, which we'll talk about in another time. But you can get that candidiasis just on a fungus growth on the inside of your lips or on your tongue. It doesn't have to be on a Kaposi's sarcoma tumor, but this one just happened to have that on top of it. And you can take some antibiotics for a yeast. It can be like yeast, fungi, infection. So this is the type of types and viruses, how they spread, and just kind of a list of the subfamily of the 1 through 8. HIV-1 infection. Let's move to that. AIDS is HIV, of course, is severe. It's a pandemic. It knows no boundaries. It's caused by HIV, which is the HIV-1 virus, and was recognized as such back in 1981. So they transmit it by blood, semen, vaginal secretions, breast milk can transmit the infection, sexual contact, of course. They do serological tests on them. The detection of an antibody in the blood occurs within 6 weeks to 6 months after exposure to the virus. So when they do these tests, they could possibly, someone thinks they were maybe with someone who had AIDS. They don't even need to be tested for anywhere from 6 weeks to 6 months because they're not going to develop any antibody until then. Incubation period is possibly 15 to 20 years. It could stay in just an incubation period and then it will rear its ugly head. So I'll let you go through that. Oral manifestations, what are we going to see with someone who is an AIDS patient? When we do the extraoral on the outside on the head, we could see purplish, brownish macules, and possibly a nodule or an enlarged lymph node. So macule is something that is super flat, like a freckle, and so it's not going to be raised. It'll just be this some kind of a shape and purpley, brownish. And a nodule is going to be more like a little knot and raised. So intraoral examination, you could see candidiasis, fungal infection. You can get candidiasis and have a fungal infection that has nothing to do with AIDS. It means that this age, and you'll go through a lot more of this and learn about that in your pathology course next term. But there's viral infections, herpes, oral hairy leukoplakia they can get really easily. They can get real easy ulcers or lesions of varicella zoster virus. Symptoms may even persist for months. So they can get also bacterial infections, 2 to 3 millimeters of red band marginal gingival erythema and NUG and NUP, and it does not respond well to oral therapy. So this is the candidiasis fungal yeast, and this is how it can just come. It can be yellow or whitish. It can go, all over the tongue. It could just be a couple patches on the tongue. It could be more than this here or less, and same with this. Comes from stress, poor diet, suppressed immune system, can come from HIV, toxicity, extended use of antibiotics can cause this in older people, alcohol, or any person actually, excessive alcohol, excessive steroids, birth control pills, diabetes, rheumatoid arthritis, chronic fatigue, and if you're constantly consuming high sugar and carbohydrates. And a lot of times it's not just doing one of those, it could be doing several of those. You could get a yeast infection. This is that linear gingival erythema that it talked about before. Linear means in a line. And erythema we have already learned is red. So it's right, I would call this marginal or linear erythema, gingival erythema on the facial anteriors right here. And this is linear gingival erythema and infection. I mean, it just looks, it's bigger, it looks infected and raised. You can see this a lot in HIV bacterial infections, but there are a lot of people, we're going to see this on, not this one maybe so much over here, but definitely this one, you're going to be able to see on gingivitis patients. Doesn't mean they have HIV. So this is NUG. NUG stands for necrotizing ulcerative gingivitis. And this is when a person has gingivitis to the max. It's gone above and beyond just normal gingivitis, but it is not affecting the perio deep down in the pockets. They don't have a lot of bone loss, or they don't have a lot of destroyed periodontal tissue yet. So they can, HIV bacterial infections, they can get this to this extent really well. This is kind of a loss of all papilla in between these this right here, and it's ulcerative, looks depressed or cratered looking papilla, and even looks like it has some pus coming out. This looks like it was kind of eaten away, and but once again, it has to do with the gingiva and not anything perio. Way beneath the gum tissue. This has calculus and food particles and everything else, and it smells horrible. You will know. You'll see some patients like this and wonder, I wonder if my patient has NUG, and you will know because of the smell. This is NUP. It's necrotizing ulcerative periodontitis. This is when it does go past the CEJ, and it is destroying all this tissue, and the bone also is being destroyed along with it. This can get this bad looking, definitely from HIV bacterial infection. Necrotizing means death, the death of tissue. So it's being destroyed. Dental management, when an HIV is suspected from any oral manifestation that you may see or symptoms, we're going to refer to appropriate medical care. What you're going to do is come get us, and we will assess the situation and see they may already be getting care. We are ethically and legally obligated to treat HIV patients. Okay, we cannot turn them away without having a legal issue, and it's certainly unethical not to treat. So we just have to use standard precautions, and we'll be fine. We don't double glove, or we don't have to put on extra things or run our instruments twice. When you're running your instruments, because we treat everybody as if they're this infectious, right? That's standard precautions. So if we're doing that for everybody, it's okay for this too, and it's worked out just fine. So for the prevention of this, you need to educate, practice safe sex, maintain oral health as best that they can, and always, always assume that everyone is infectious, highly infectious, and you will not forget to use all of your PPE. So this is the end of this. Once again, I'm sure you're sorry. This is the documentation part. We have to note the patient's medications and effects, record consultations with any specialists, record referrals and the purpose that we're referring them, and record lab values if they come back with anything and tell us any of their lab values. So once again, probably be shorter if you just read the chapter, but I like to give pictures, which makes these a little longer. us, especially for those who have not ever been in a dental office, so that you can get an idea of what it's actually supposed to look like. Since this whole term, we're not really going to be looking in these type of patients' mouths. It's just easier to understand and remember, I think, if you get a visual. So with that, this will be the end of this section.